Hey everyone, let me know if you can hear me in the old chat. Hey Allison, how's it going? Perfect, yep, we'll get started here in just a few moments. 10-4, good buddy, that's what I say. Maybe one day I'll own my own truck. Actually, if you talk to Ben Anderson from your upper class, he will talk about truck gang, of which I am a member, having once owned a truck. Truck gang for life, apparently. And I think we finished up the therapeutic drug monitoring. Not a big rig truck. I had what I like to call the Danger Ranger. It was my college vehicle / moving anyone that I came into contact with. Let's see. On the assignment, do you want us to write like 7-day dose pack as the dosage? Okay, I'll talk about that. Let me get everyone in, and I'll kind of address those questions. But yeah, feel free to go ahead and put them up in the chat early so I can address them when we get started. Hey, cassette. Like my invisible water bottle. Hopefully you guys don't have to hear too many mouth sounds as I'm drinking. But staying hydrated is important, as it turns out. Abby says, I calculated an interesting number for the 21 kilogram boy. Is that correct? It seems hard to have a parent dose it out with a weird dosage due to his weight. For the PEDS RX, if we get a daily dose that has decimals and anything beyond the hundreds place, do we have leave it for the pharmacist to determine? Interesting. All right, I might actually work through an example problem just so you guys get a better sense for that kind of stuff. So I'll use a different. Yeah, I'll walk you through the process. So we'll come up with something here. Seeing some interesting chat here, so I'm gonna clarify some things for you guys so you have a little bit better idea. Which I think the section will be a little bit quick anyway, so it should be okay. .05 grams daily. That does not sound correct, but we'll work through an example problem. It is 2:30, so we can get started. Actually, this is a good picture. I don't want that. I want the picture. Okay. So let us, Kyle, I got, interesting. So let's work through an example problem. Let's say, let's get a new word. I was going to use that for another thing, but let's go ahead and use a new Word document. Okay, so let's just take for example, and I'm going to start recording as well because that would be handy in case something goes down. All right. Right, so let's do an example here. Let's say we have a patient who has some sort of infection. I'm going to bring up a lexicomp here, and we're going to use the drug ceftonir. We're going to learn about ceftonir next semester, but it's a pretty common antibiotic. Omnicef is a pretty common brand name for that. But let's say, for instance, we're going to have a, I don't know, 31 kilogram kid. Actually, let's go lower than that. How about 18 kilograms? 18 kilogram child. They're going to have an infection. And so let's say they have, we'll go with the same indication here. So let's say they have acute otitis media. So for this, they're going to get 14 mg per kilo per day in divided doses every 12 to 24 hours for 5 to 10 days. Okay, so, and remember, like, when you're looking at this in the future, like, because I kind of told you exactly what to do in terms of length of treatment and the actual how often. I guess I didn't say how often you should get, but whatever I said, I was being very specific. In the future, I'm going to be less specific than that because I'm trying to kind of break you into it, but also two, in the future, I want you to be able to kind of discern these things. So you as the provider have to make the decisions in terms of, do I want them to get it 12 or every 12 or every 24 hours? Do I want them to get it for 5, 7, 10 days? You got to be able to make those decisions. And we'll talk about things that may go into that in the future here. So one problem I see students run into frequently is they'll put a lot of ranges on there. And like, that's not for the patient to decide. You're the provider. You're deciding what they're supposed to get. So let's go ahead and take this. And let's say, I'm going to go ahead and say we're going to do 14 mg per kilo per day. We're going to do it every 12 hours. And then we're going to do it, say, for 10 days. Okay, maybe they had recurrent otitis media. Maybe this is the second or third time they're coming back, and so they need the longer duration of treatment, right? So, again, what's our first step going to be? How are we going to do that? Well, we need to figure out what they're actually going to get per day, right? So if I have 18 times 18 kilograms, to keep my units straight, times 14 mgs per kilo per day, I should end up getting, and again, I'm just making this up on my own, so let me bring up my calculator so you can do it with me. 18 times 14 is 252 milligrams, right? So 252 milligrams per day, right? And this is exactly how I would figure it out if I was doing this in person with a provider, if we were doing it, you know, say in the PTR or something like that. Now, we do know that they're getting 2 doses per day, right? So if I'm getting, you know, basically I just have to divide that by 2. So I can divide that by 2 doses per day. Basically, I'm going to end up getting, they should be getting half of that. So 252 times, or just do divided by 2. I get 126. So they should be getting 126 milligrams, not nanograms, per dose, right? All right, so that's all well and good, right? But again, I can't just write it on the script, give them 126 milligrams per dose twice daily for 10 days. That doesn't really make any sense, right? Because the patient or the caregiver needs to know how to convert that over into an actual volume. So let's go back to our lexicomp and let's go down to dosage forms, and we can see what's commercially available. So it has a capsule, an oral capsule. Well, you know, young kid, they're not going to take that. So instead, what we're going to have here is this suspension that we can reconstitute. Now, interestingly here, you're going to find that there are a variety of concentrations, and these are the bottle sizes that it comes in. You as a provider, you're not really going to care about the bottle size. Why? Well, because we'll see in just a few minutes, right? So I'll keep you some tantalizing bits of information to keep you engaged, right? So we got to figure out which concentration we're going to be using here, whether the 125 milligrams per 5 ml or the 250. Now, I will tell you that in general, if I can use a smaller volume and give that to a kid, that's going to be preferable to a larger volume, because otherwise, the more volume it is, the more they're going to be able to spit back out at you. So let's say we're going to go with the 250 per 5. Okay, so we're going to use a 250 milligram per 5 ml concentration. I like to divide that out, so I can go ahead and just make that equivalent to 50 milligrams per ml, right? So now what I'm going to do is go ahead and take this and say, okay, well, I got 126 milligrams per dose, and I'm going to divide that by 50 milligrams per ml, and I should be able to get how many mLs it's going to take, because again, my milligrams are going to cancel out. I should get mLs per dose. And so I'm going to take that 126 divided by 50, 2.52 mLs. Oops, 52 mLs. That's per dose. So now we got the first part of the script kind of done. We've got the volume figured out in order to how much to actually administer to the patient per dose. Okay, we're not done yet though, right? We got to figure out some other things too. The question is like, okay, well, what can the patients like reasonably actually measure, right? So that's a question. So you can get decimal places out to the millions place, but it doesn't mean anyone's going to actually be able to do anything with that, because it could be too difficult to actually measure that, right? So again, let's go and look at. See, where's this picture go? So this is a pretty typical dosing syringe, if you can see this here. I can get this a little bit bigger. So what you notice is, and most of the time you're going to find this is how they will look. So this is a typical 10 ml oral syringe, and what I want you to notice is the demarcations here. So the major marks here are going to be the number of mLs. And again, some of this may seem like totally obvious to some of you, but again, I want to make sure everyone's on the same page. Now the question is, what are these tiny demarcations here, right? Well, it's not tenths, because you can see that there's not 10 markings in between here, but it's actually going by 2.2, 4, 6, 8, and then 3 mLs, right? Notice they also have these teaspoon markings here, but we don't like to use those too often because, again, you know, it's fine to use it here because it's pretty exact, but we're getting away from doing that anyway, just sticking with the metric system. So what could this patient reasonably measure out when doing this? Could they measure 2.52 mLs? Well, not likely. That 0.02 is unlikely to be measured here. So what can they do? Well, they can kind of roughly estimate it and say, okay, 2.2, 2.4, and then right in between here, 2.5. They could probably measure that out pretty reasonably well, right? Is it going to matter if it's 2.4 or 2.6? Probably not in the grand scheme of things, right? So as long as they can kind of get that. So what I would probably do is just round that down to 2.5 mL. So I can just say, okay, I'm going to go ahead and give them 2.5 mLs per dose. Okay? Good so far. So how would I write that if I was to write out the actual script if I were doing this? And again, if this is not helpful, you guys can just let me know my evals and all that. So basically I would say do all the normal patient information here, but I would say Ceftonir. If I want to be fancy, I can go ahead and say Omnicef. We'll talk more about brand names and stuff on prescriptions in this talk here and coming up, so this is a perfect segue. So let's say Ceftonir, Omnicef. We're going to say we have to make sure we specify the concentration, because if I don't specify that concentration and then the pharmacist fills it with whatever they feel like, which is not something we would do, we'd always call. But if they wanted to fill it with the 125, then the patient's only getting half as much drug as they actually should, which is not great. So make sure you specify your concentration. This is really important for liquids, okay? So we're going to get, and we can say oral suspension, okay? So this would be the first line. This is the drug and the strength, and now we have the dosage form too, because we know it's an oral suspension. You can say take, and we're going to have our dose here, so 2.5 mLs. Now we got to make sure we include our route, so that way they don't end up with it in their ear or something like that. So we're going to say 2.5 mLs PO BID times 10 days. Now that's the shorthand way to put it. If you wanted to take 2.5 mLs by mouth and actually write it out twice daily, that's totally fine. What I'll tell you is on the pharmacy side, when we type all that stuff into our system, it'll automatically lengthen that out. So this is not what's going to be on the prescription label. It'll actually say take by mouth twice daily, all of that, specifically so that way the patients can read it, because most of them don't know what POBID actually means, right? So we have that. Next, we want to get our quantity, right? So how much do we actually need to fulfill this whole prescription? Okay, now a lot of students will go ahead and just put like bottle amounts. Don't worry about that, right? So what you need to worry about is just making sure you write down the full amount of what they need to fulfill that prescription. On the pharmacy side, sometimes we'll give them exact volumes. Sometimes we'll give them the entire bottle, even if it's more than what they need, and tell them to toss the rest out when they're done with it. Reasons why we might do that includes like the actual stability of the drug. So a lot of antibiotics come as a powder form that we reconstitute. We put water into it to put it into a suspension. Those drugs typically have a short stability. So if we can't keep it on our shelves for more than 10 or 14 days, we don't want to keep it around. We'll just give the extra to the patient. It's not a big deal, right? And tell them to throw away the rest when they're done. If it's something that has a long stability, then we would pour out an exact amount. You don't really care about that though, because you're the provider. You're just telling us how much we need to fulfill the actual prescription when we dispense it, right? So let's go ahead and figure out how much we're going to need for that. So going back to our calculator, We know they're getting 2.5 mLs per day. We know they're getting 2 doses per day, so they're getting a total of 5 mLs per day, right? And then I know they're getting it for 10 days, so do 5 times 10, and boom, they're getting 50 mLs. So you could just write on here 50 mLs. Now, some people will write extra in case like the kid spits it out or something. Don't worry about that. Just write, again, we're just trying to make sure we get the actual basics down here. So we're going to write 50 mLs. And if you recall, if we go back to the actual dosage forms, we would probably just give them the 60 ml bottle, right? So that way they have some extra already built into doing that. Okay. Kyle's asking, would there be any benefit of choosing the 125 per 5 strength over the 250 per 5 aside from what's available at the pharmacy? Yeah, so if it's a pharmacy availability thing, we might actually automatically sub that out, and we would go ahead and change the concentration, or we would use a different concentration and fix the dose. Sometimes that happens due to shortage. Sometimes if you're using really small doses, we would use the less concentrated form, so that way we have more volume to work with. It just really depends on the situation. We do that a lot for IV drugs, especially when we have like little tiny neonatal kids. We're giving like very small infusions to. We have to make sure we dilute things down to make sure that there's enough volume to actually measure that stuff out. So, but that comes up, most on the pediatric side of things. So yeah, if anything, try to use less volume if possible, because that way the kid has to take less of it. I imagine if you could take medications, if you remember taking it as a kid, you'd probably want smaller volumes as well. So anyway, so do 50 mLs, and then, for my refills, you say, okay, well, would you include any refills on a prescription like this? No, because it's an acute infection. I don't want to necessarily treat this as a chronic sort of thing here. And I said only for 10 days, so I would say 0 refills. Now, on the other hand, could there be reasons why you might do this? Yeah, we'll get into that next semester. But what if you have someone who has chronic cystitis, and so they get UTIs that pop up every once in a while? Sometimes you might actually give them some refills on this, so that way they could go back without having to come see you every time they get a UTI. So, yeah, as long as it was bubblegum flavor, I didn't mind. Yeah, I just remember my medicine always tasting awful. But nowadays, especially at the poison centers, a lot of parents will call up and they said they drank the entire bottle of Tylenol. It's like, yeah, because the bubblegum flavor tastes awesome, or they'll drink a whole bottle of ibuprofen. It's orange flavor. It's like, yeah, don't make it taste so good. Otherwise, they'll drink it. But regardless, this is the general process, right? So this is how I would go about determining how to fill one of these prescriptions here. Looking at the sticky board real quick. So someone said I'm having a hard time calculating how much to take for the prescription assignment. Hopefully that clears that up a bit. You'll have an idea about how to do that. Oh man, the orange Motrin was good. Yeah, it definitely is. And also it's good we have like flavoring stations. We can make this stuff taste different flavors if it's something the patient wants. But yeah, there can be some drawbacks to that. Yep. All right, we're gonna have a little battle here in the chat over what the best flavor of medicine is. We can all agree though that the purple drink, putting a little bit of a Phenergan codeine together, it's just that's the best. I'm just kidding. Don't do that. Don't drink the scissor. It's not great. I said pharmacists choose what bottle is dispensed. Yeah, we'll figure out which one to give to the patient there. So Marley's saying, so you don't have an exact number that gets you to 50, but in our case we don't. We get a number with decimals. If we write out the decimals, it's at the discretion of the pharmacist to choose the bottle. Yeah, we'll figure that out. So as long as your quantity is enough to fulfill the prescription, if I do the math that you have on there and it makes sense, then you're fine. I don't care about the bottle sizes so much, right? So Abby's saying, so for the daily grams on the pediatrics, I got 1.05 grams in order to get 13.125 mLs in the whole prescription, but how do we write that? I would write it just like here. I would double check your numbers on that one, right? Make sure you get everything down into mLs first in terms of like the volume to figure all that stuff out, right? You don't want to necessarily, so like when I did this and I said the patient needs 252 milligrams per day, I didn't multiply this by 10 to get the total amount. I made sure I got everything down into mLs first, and then I figured that out. Okay. So yeah, Abby may want to go back to the drawing board. I would double check that because that doesn't sound correct, but I would have to look at the prescription assignment again, which I'm not going to do right now because I'm already 15 minutes into the talk already, and I'm way behind schedule. So, let's see, for the prescription assignment, what do we do if the quantity of suspension is greater than the amount commercially available? We will either give multiple bottles, or we will give combine it into one larger bottle, right? So that's occasional we'll do that. I know my kids one time had to take Tamiflu, and we went ahead and just the pharmacist gave us 2 bottles because one was not going to be enough to fulfill the one prescription. Let's see, what math calculations are we supposed to know to do? Well, I mean, you really should be able to figure out any of this stuff here we're talking about, right? So you should be able to do simple math in terms of multiplying things together. In terms of the test, I will talk more about that later, so don't worry too much about that. There will be some math on the test, but because you guys want to have scratch paper, it'll be very limited math. It'll be pretty easy, and you will have a calculator activated in Canvas. So, but don't worry about that too much. We'll get to that. As long as you can follow your units, you'll be totally fine, okay? Anyway, so let me get back to the topic at hand. All right, so we're doing Unit 7 here. We're getting into designing dosage regimens. So how in the heck? So we're like, let's put everything together and figure out what we're going to do with all this information that we have here. And so one of the things I want to talk about here is this idea of rational prescribing. I got to work at Nemours yesterday, and I saw plenty of examples of irrational prescribing that I was able to have varying degrees of success in order to rectify, but that is the lament of the pharmacist, right? Marley's saying, in a real-life scenario, would this be done via a computer system, or does the pharmacist / pharm tech physically calculate things? I always will double-check what the provider does, and I think most other pharmacists would do this. That way we can make sure that everything matches out. And so also our computer systems will do the same thing. They'll calculate out what makes sense. And what's interesting too is that, and again, I've limited retail experience just because retail is not really my jam. But one of the things you'll see is they actually will send it over to the insurance company too. And at the insurance company, they look at the instructions and it doesn't make sense with what the quantity to dispense is, they'll actually reject it. They'll say, well, this is too much. There's no need to give that much drug for those instructions. So there's multiple checks along the way to make sure all that math is correct. And again, I would always call and double check with the provider if I saw anything that did not seem correct. So anyway, let's go back to an example. So, once you guys have kind of done your job and you've assessed the patient, you've ordered your lab tests, you've come to your diagnosis, and you figure out what the patient has, typically many different types of therapeutic approaches are going to be made here. So does the patient need surgery? Do they need radiation? Frequently though, medication is going to come into play, right? And so this is most common because a lot of disease states have medication options available to them. It's relatively quick and easy as opposed to some of the other options, but it likely requires a prescription unless you're in a hospital setting. But for the most part, most of you are going to end up writing prescriptions at some point in your career, right? So getting into, one sec here. I'm trying to manage all my windows over here to make sure everything looks good. All right. So, when you have a patient comes in for a visit, like 2/3 of the time, they're going to expect to be getting a prescription from you, or they are going to get one from you, and probably closer to 100% are going to expect some sort of prescription, Nothing worse than going to a provider and you say, oh yeah, I'm feeling sick. And they tell you, oh, it's a viral illness, you don't need any antibiotics. You kind of feel like you got gypped a little bit, right? If you don't get, kind of come away with anything. But that's obviously not going to be the most appropriate thing to just give a prescription to everyone. So we're going to look at some ways to sort of get around that and some of the ideas that go into how we do this process here. So again, when we do rational prescribing, you should follow this sort of stepwise approach, and you'll learn more about this as we get into the details here in the upcoming semesters. First off, though, you have to make your specific diagnosis, right? And frequently, as we mentioned, patients want you to do something. You don't want to just say, okay, well, you have this condition, but we can't do anything for it, so we're just going to watch it. Not super satisfying to a lot of patients there. And so if you're writing prescriptions just to satisfy the patient, then one, that can lead to unnecessary cost. Frequently, this is related to using antimicrobials for viral indications, which can lead to a lot of resistance. And then you're introducing the possibility for more drug reactions that could be worse than the actual whatever they came in for in the first place, right? But you need that tentative diagnosis. You got to know exactly, or specifically, what do you think they actually have in order to make the next step here. So let's go with an example, and let's say we have someone with probable rheumatoid arthritis, And so you should talk to your patients and make sure they understand why you're making this this assumption, why you're coming down with this, in terms of the lab test you did and everything else, right? So then step 2, you want to consider sort of what the pathophysiology is in terms of the diagnosis. So this is why it's really good to have a good understanding of the physiology of what's going on normally so that we understand the pathophysiology, and you'll know how your medications are going to be interacting here. So if you have someone with rheumatoid arthritis, you know that there's going to be a lot of inflammatory mediators that are going to be playing a role here, and also let you know that, okay, well, maybe I can use something that as an anti-inflammatory. Maybe I can use steroids, or I can use non-steroidal anti-inflammatory drugs. It'll kind of give you a list of drugs you can think about using based on that pathophysiology, right? And again, when you're talking to the patient, you may give them a medication and they may not really have much medical knowledge, and so you can say, okay, well, this is for your blood pressure, right? Or you may, if they have a little bit more knowledge, be able to explain to them, this is why I'm using this medication, because it's going to work better for you as this type of patient here. There's a lot of good resources online. If you look at LexiComp, or as I mentioned, through UpToDate, it's the same thing as LexiComp. There's patient education information there that will talk about the drug at varying levels of education, and so that can be useful to make sure you're communicating your point effectively. Next up, you want to sort of select what's your therapeutic objective here. So based off of the pathophysiology, and you identify all of those different processes going on, develop what your therapeutic objectives are going to be. So in the case of someone with RA, and you're going to learn more about this next semester, but basically we want to relieve the pain they're experiencing in their joints, which is due to this acute inflammatory process, kind of more of a chronic inflammatory process, to be honest. And then if we can, we'll have a secondary goal to try to arrest the course of disease. And so some diseases you may be able to do this, some you may not, right? Sometimes your one goal is just to eradicate whatever it is, and then you're done with. Sometimes a one and done thing, sometimes it's a chronic thing. But looking at this, we can see one, we have relieving pain associated with inflammation, and then one, we want to slow down the disease process. And so these are different goals, and so because of that, we may need different groups of medications to help out with that. Sometimes drugs may be able to do both, sometimes they may not be able to. So that's why you can see multiple drugs being used for the same indication. They're doing different things. So now we have to select a drug of choice, right? And so you may find that there are multiple groups of drugs that can provide and fulfill a certain goal. You may find that you have to take specifics into account to determine what's going to be the best medication group for that particular patient. So based off of their age, their disease states, and maybe what other medications they're already taking. Maybe they have a new diagnosis of RA, but they already have a history of MI, CHF, osteoporosis, all these different things, right? So as an example here, one of the big classes of drugs that we use for patients with RA is going to be non-steroidal anti-inflammatory drugs. And so one of the things you may ask is like, well, do you have a history of maybe aspirin intolerance, which aspirin is still considered an NSAID, or maybe a history of GI ulcers? That may preclude you from using a certain groups of drugs because they may be more likely to develop these really serious complications, like having a peptic ulcer develop there. You may consider, do they have insurance available in order to help pay for some of these medications? We'll find some of these, depending on the class we're using, can be extremely expensive. Yeah, you can go get ibuprofen over the counter, quite cheap, but some of these other drugs we'll talk about for the use of RA can cost thousands and thousands of dollars because they're engineered monoclonal antibodies designed to inhibit inflammation, all this kind of thing. So it can vary widely. And then, think about things like compliance. Is it, can you get away with once daily dosing? Is it something to where you can use combination pills, getting more than one drug into one pill? So that way that can help out with compliance. Figure out what's going to be important for your particular patient based off of these considerations. And then once you have your drug selected, you want to determine the appropriate dosing regimen, right? So this kind of goes into some of the things I was talking about in the example when I went through and deciding, okay, well, with ceftonir, I had a range of options, right? I could give the drug one time a day, twice a day. I can give it for 5 days or 10 days. These are some of those considerations. I may say, well, it's a kid, so I want to use maybe one-time daily dosing, so I just have to give it to them once a day, and I don't have to worry about them spitting it out at me multiple times a day. Or maybe I choose 10 days instead of 5 days because this is a recurrent problem for them. They have a history of antimicrobial resistance. These are the things we think about when determining these issues. So again, looking at the appropriate dosing regimen, we consider things like the kinetics of the drug, like how long is it going to stick around? Does my patient have kidney dysfunction that's going to make it so that the drug has a longer half-life than some other things? So these are things where you may have to consider either not using a drug altogether, or maybe altering, say, the frequency or the dose that we're going to administer there. And again, what's the patient going to tolerate? Are they going to be able to take something multiple times a day, or are they only going to be willing to take things one time a day? Or can they use a patch that they only have to do every 3 to 7 days, depending on the drug. So, and then you've got your drug, you have your therapeutic plan in terms of how to administer it, but then you have to think about how we're going to monitor for the effects of the drug's actions, not only for the efficacy for how it's working for the disease state, but also like what are the drawbacks, what are the side effects that we need to be monitoring for, right? And so that can include, laboratory testing to see if things are changing. So for instance, if I'm giving someone diabetic medications, I'm looking at their A1C along with their blood glucose. I may be looking at their weight. I may be looking at lots of things there. And again, you want to explain sort of like the rationale, especially for like the prescribed duration of use for these patients at this time. Because when you're talking about endpoints, that can be important because some disease states may have a very clear defined endpoint, like I cure the infection, or it may not be the case, right? Think about HIV. It's a lifelong thing people end up having to deal with until we find some curative means to treat that. And so for here in this example, with antibiotics, talk about, why do they need to take the full course? You tell them to take a drug for 7 days. They feel better by day 5. They say, well, I don't need to take the rest of this. Well, they really do, and it's your job to explain to why that's so important. You can't always count on the busy pharmacist at Walgreens who's filling 300 plus scripts a day to do that. Should they? Probably, but they may not have the resources to do so. So you need to take it on you to be that person that's going to explain all this stuff. Also explain what would constitute a change in therapy, right? So if they're taking an NSAID, what are the things they need to worry about in terms of like if they experience a peptic ulcer that starts to bleed? Okay, well, maybe they have hematemesis, or maybe they have dark tarry stools. There could be lots of things you're going to be looking for depending on the drug class. Is you need to be able to explain to them what's normal, what's abnormal, and what may constitute need to actually come back in and change that therapy altogether. So, and then you want to make sure you're planning a program for patient education, right? So make sure you find ways that are specific to your particular patient, right? Here in Florida, this is where a lot of people come to die. It's what I call heaven's waiting room, right? Especially with our COVID cases exploding. But you have a lot of older patients. So maybe there's an age issue. Maybe they have hearing deficits you have to get around. Or maybe they can't read the patient or the handouts you're giving them because they've had some vision impairment. We have a lot of language barriers. We have a lot of Spanish-speaking patients here who don't speak any English. And so we need to have means in order to help communicate with them. We're a big travel hub. So you have people coming in speaking Portuguese. You have people speaking Chinese and Japanese and all these different languages. And so we need to have systems in order to help us kind of get around that and able to communicate with our patients. And then educational barriers are also huge, especially if you're working in more rural areas. These people may not have a whole lot of medical knowledge, and so you need to be able to explain it to them on sort of a more fundamental level so that way they can kind of get why this stuff is important. Okay. Utilize educational materials when you have the ability to. So here's a good example. I like this one. This is a drug called Diastat, or it's kind of blurry, but you can see this is a diazepam. It's a drug we use to treat acute seizures for patients outside of the hospital realm, right? So if they're out in their home or whatever, they would carry this around similar to how someone would carry an EpiPen if they had a history of severe anaphylactic allergy to something like peanuts, for instance. This is a rectally administered gel, right? And again, when a patient's seizing, they can't give it to themselves. So this has to be a caregiver, a parent or guardian or someone who's going to be able to administer this. And so this is really important you do this correctly because 1, you want to stop their seizure, but 2, this has to be rectally administered. And so if someone doesn't know what they're doing, they may not be able to do this effectively. So for instance, one of the big things you have to make sure they do is apply lubricant to here, because otherwise you can cause rectal trauma if you're trying to insert this without doing that. And again, if someone is seizing in front of you, you may be a little apprehensive. You may be a little anxious in order to make sure that you're taking care of the patient, especially if you're not used to it. So for like a lot of first-time parents who have child who have developed epilepsy, things like that, this can be really important to make sure you walk through them. And if we have the ability to use like trainer models that let them actually hold it and see what it feels like to actually administer it. We do this a lot with like trainer EpiPens, so people know what it's like to administer it to either themselves or to someone else. That can be really important because, again, when someone's seizing right in front of you or they're having anaphylactic allergy, you don't want them to be second guessing on how to actually use it. They need to use that medication now, and so that's why you need to educate that really early and reinforce that stuff. And again, using a teach-back method can be really important too. So saying, okay, so I already told you how to take this. Now you tell me how you're supposed to do it. And have them walk through it. So that way it's kind of that C1 do one, teach one kind of model, so that way they can at least get some of that experience and learn how to reinforce what they're supposed to do. And again, pharmacies will provide a lot of information in the bags they hand over to the patient, but don't assume they're going to actually take the time to explain it unless someone actually asks. I'm sure many of you had filled a prescription before, and you just go up to the counter, and the tech is doing the transaction and say, "Hey, do you have any questions for the pharmacist?" And they look busy, and you don't want to bother them, so you say, "No, I don't have any questions," when maybe you really do. Right, a lot of patients experience this, and so it's just one of the unfortunate things with retail pharmacy is that a lot of people don't get that opportunity to interface with the pharmacist. So let's go through another example. Let's say we have another patient with otitis media. This is pertinent because it goes along with our example used before and also with our prescription assignment. Or actually, did these have strep? I think I had strep actually in the prescription assignment, but this is good for the one we used previously. So let's give an example here. We have a 3-year-old patient who presents with left ear pain. They have a fever, cough, and runny nose. You get your otoscope out and you see this nice red, angry looking tympanic membrane. You say, "I've got it." Pretty sure they got acute otitis media, right? And again, when you come up with your diagnosis, be able to explain the etiology to the family, explain why I think it's this versus this. Could it be viral? Possibly, but it's also very likely to be bacterial. So this is why you're going to be going down a certain pathway in terms of determining what drugs you're going to use, how to use them, etc. So next, again, you want to consider what's the pathophysiologic implications of the diagnosis here. So when I'm thinking about infections, frequently I want to think about what are the most common causative organisms, because that's directly going to affect which antibiotics I'm going to use. And so don't worry about memorizing this list here, because we're going to learn about it next semester. You'll learn about it from Professor Q when he does ENT. You're going to learn about it from me when we do bugs and drugs. But some of the most common bacterial causes of acute otitis media include things like strep pneumo and H. influenza. And so you're going to see this for a lot of upper respiratory tract infections. And so by knowing that, instead of thinking, oh, well, it could be MRSA. Well, it's probably not going to be MRSA because it's very unlikely that normally does not cause acute otitis media, right? So again, most of the time you're running off of probabilities, right? What's the most likely thing here? So this helps you to tailor the antibiotic therapy. So I don't need to use antibiotics to treat every single bacteria under the sun, because I can be more focused and I can be more narrow. We're going to see that's a really important thing when using antibiotics, because if we're using inappropriate antibiotics, that leads to resistance, and that leads to the super bugs. They're going to end up causing the end of the earth. Actually, it's probably more like COVID at this point, but maybe the super bugs will come up maybe that's going to be October surprise first or something, or maybe super bugs in October, and then it'll be aliens in November, and then we'll go from there. But again, provide that information to the parents and families, because they may say like, oh yeah, well last time my other child had an ear infection, they got this antibiotic. How come they're using this one this time? There could be reasons for that, but you need to be able to explain why that is to the family. So what are some ways we can try to educate people about that killer clowns in August? I hope not. Didn't we have killer clowns last year? I think we did, but they were pretty light as compared to what we're hitting nowadays. But maybe they'll have a comeback. But so there's lots of resources out there. So especially things like the CDC, although some people may not trust the government, but I think they're still a pretty good resource. So they can read this stuff. They can educate themselves a little bit. And it's nice because they even tell you how to pronounce things. And that way they sound a little bit more intelligent and kind of go through all of that process there. So point them to the right resources. Now we have to select a therapeutic objective, right? So one goal obviously is to eradicate the bacterial infection, right? We're going to use appropriate antibacterial coverage. So when I say coverage, it means we're using drugs to treat those specific bugs that we think are causing that infection. And then also we want to treat any sequelae of the disease. So in this case here, the kid came in with a fever, and people feel miserable when they're having a fever. So we can go ahead and treat that as well. So two goals. And we're going to see that while the antibiotics may eventually help out with the fever, they're not going to do anything right away. And so this may require the use of multiple medications, right? So now we're going to select our drug of choice. And we're going to take into account the different specifics about the patient in order to determine what's going to be best for them. So age of the patient can be important. The organ function, if it's an otherwise healthy kid, they probably have pretty good organ function. So I'm not too worried about that in this particular instance. Do they have allergies? Maybe they have a history of penicillin allergy that's going to preclude me from using a lot of the antibiotics that are sort of like your bread and butter stuff for otitis media. And then look at their previous or current medications. Is this the third ear infection they've had in the past year? And have they been on different types of antibiotics previously? That may influence what you're going to choose now. Do they have current medications that may interact with what you potentially may be prescribing for them? Again, another consideration. And so use your resources to find appropriate medication. And so I did have a couple questions that came up about this from some of the students. We get lots of emails about the prescription assignment. And again, when people say like, well, I looked at this one reference and it said this, but then I looked at another reference and it said this. Like, what's the difference? There could be a lot of different things going on there, right? Sometimes you may find conflicting information depending on where you're looking, and that's normal. That's a part of medicine. Some of it is related to, for instance, clinical opinion, like expert opinion, especially if we don't have good evidence to show us why one thing is the absolute correct right answer every time. Sometimes it could be related to which evidence they're particularly looking at. So again, you can use things like Lexicomp. There's other ones out there like Micromedics. There's clinical pharmacology. You do also have access to clinical pharmacology through the Nova library, so I suggest you check that one out too. This one's nice. It's a little bit more narrative in terms of how it's writing things out, so it's a little more easily readable, I think. Lexicomp's kind of strict and to the point. But for specifics in terms of infectious disease, there's other things we can look at. So for instance, there's the Sanford Guide. This is a really good standard sort of reference for infectious disease topics because it kind of covers everything. And I'll take an opportunity to show you this next semester when we get more into the infectious disease stuff. But this is a really good resource. You can click the links here and get to that in the Nova library, I believe. It should still work. And then there are other ones like the Red Book. The Red Book is called the Red Book because it's a big red book, but it's specifically about pediatric infectious disease. And so every pediatric ER you go into, probably a lot of other ERs are going to have this available to you, so you can look it up and see what is the most appropriate there. The gold standard, though, is always going to be clinical practice guidelines. And so depending on what you're looking at, and frequently students will come up and say, well, what's the best thing to do for this? And I'll say, what do the guidelines say? Because the guidelines are frequently going to be having the most up-to-date information. They're going to have the most senior experts in the field and telling you specifically what we know about the topic, what's the best way to manage it, and maybe what we don't know yet as well. So what are the underlying questions here that we don't know? And so, for instance, with infectious disease, maybe you want to go to the Infectious Disease Society of America. That's probably makes pretty good sense. The American Academy of Pediatrics will also have good information there regarding the specific topic. So you can search around and kind of figure out where the guidelines are. And honestly, you can just Google acute otitis media guidelines, and you're going to find this stuff pretty easily. Most of it's pretty well available. Otherwise, you can go through the Nova library for sure. But if you have a question about OB-GYN, like we'll go to ACOG. ACOG is the American College of Gynecology or gynecologist, something like that. But regardless, you can go check that out, and you'll have all kinds of answers for many questions you might have. So once you've got your reference, you select the drug of choice. In doing that, you got to determine, okay, well, how often is the drug given? What's going to be more beneficial for the patient? What dosage forms are available? You saw with that ceftiofur, we had capsules that are available, and then we had the suspension. Well, if the kid's young enough, then the capsule's not really going to work. Whereas if they're a little bit older, maybe that's totally appropriate. Sometimes we have drug shortages, right? So that may dictate which concentrations we're using, what's available, what flavors might be available, unfortunately. See, someone said made bacon and chicken flavored for pets. Yeah, so maybe we ran out of the orange flavored drug, and now we got to go with the bacon and eggs flavored. Who knows, right? These things can tend to happen. But also we want to think like, well, how much does it cost? Like, does the patient have insurance? Is insurance going to cover it? Are there free antibiotic options? You'll find that a lot for places like Walmart and Publix. They offer your free antibiotic options. To some degree, it's a limited set, but they offer some, and you're like, well, why in the heck would these companies offer free antibiotics? Why are they just giving this stuff away? Well, if you think about it, it does make pretty good sense. If you ever heard of the term loss leader, basically you'll have parents come in, they got their kid with their snotty nose and they're febrile and they're just feeling miserable. So you go and you go say, hey, I got this script here for a free antibiotic. Say, okay, it's going to take 30 minutes. And say, all right, well, I got some Pedialyte now, and I got to go get this and that, and some Tylenol. And so by the time you end up getting that free antibiotic, they've made up all their money on everything else you bought while you're at the store. So, but those options are available. You can look that up pretty easily. And then how palatable is the medication, right? So is it a texture thing that the kid may have a problem with? Is it a flavor thing? There's a million things that can go into this. For instance, I have a hard time when kids ingest accidental drug ingestions, right? Sometimes what we'll do to try to absorb that medication to prevent it from being absorbed is give them something called activated charcoal. which is exactly what it sounds like. Basically, it's charcoal. It's been super compressed to have this like really high surface area. But the problem is that while it tastes pretty good. I've tasted it before. It's sweet, but it has a very gritty texture, right? Just like you might imagine ground up charcoal would have. And so sometimes what we have to do is try to mask that. So for instance, if I can give it to a kid in a cup with a covering on it, so when they don't see what it looks like, because this is really black, kind of sludgy looking stuff, they kind of don't like that. But then actually I can put chocolate milk down the straw or chocolate syrup or something, and that will mask a lot of that texture for them for whatever reason, and then that way it's more palatable. Again, sometimes you got to find ways to get around things. Sometimes I can put medications into citrus, and that will cover up some of the taste that may be adverse to the patient. So a lot of ways to get around this. We'll learn more about that as we go through it. But let's select an appropriate dosing regimen. So we have our drug. We know what we want to use. Now, this is actually taken from the AAP guidelines for acute otitis media. And you can see here, they actually walk you through and tell you specifically what you should be doing depending on the situation. So for instance, if it's an initial, immediate, or delayed antibiotic treatment, so say your patient just came up and they had an acute otitis media, you would start here. So we could use a recommended first-line treatment, or we could use alternative treatments if the patient was penicillin allergic. We'll learn a lot about penicillin allergies next semester and what drugs you can use and you can't use. But it just basically tells you, okay, amoxicillin, 80 to 90 milligrams per kilo in 2 divided doses. Easy peasy, right? The guidelines will also tell you how long you should be treating for as well, probably in a different section. Or maybe you could bump it up and use something like the combination of amoxicillin and clavulanic acid, for instance. And then they even tell you, okay, well, what if that patient was given a prescription? Maybe they got a prescription for amoxicillin, but they don't really respond well after 2 or 3 days. Well, what's something else I could use as an alternative, right? Maybe using some bigger guns or something that's able to treat more resistant bacteria, for instance. So they kind of walk you through step by step what you should use, and it takes out a lot of the guessing work. And a lot of the stuff will become second nature to you if you deal with the same disease states over and over again. So if you work in family practice, you're going to know all the diabetes stuff and all the hypertension stuff. If you work in a PDR, you're going to know the stuff like the back of your hand for sure. So let's say we decide to use amoxicillin suspension. We're going to use 90 mg per kilo per day, divided twice daily, and the suspension comes as a 400 milligram per 5 mLs. So this is kind of like the example I was using previously. We mentioned amoxicillin being for that prescription assignment. This is kind of the same thing, just for a different indication. So there is different dosing associated with it. So in this case here, the patient weighs 20 kilograms. Well, let's figure out how many mLs they need to take per dose. Do I actually calculate it all out? I did. So you can see here, they're doing 90 mg per kilo per day, divided twice a day. Okay, so suspension comes as 400 per 5, and they weigh 20 kilograms. How many mLs per dose? Well, first off, figure how much you need per dose. So it's 45 mg per kilo per dose times 20 kilograms. Okay, kilograms will cancel out at 900 milligrams per dose. Okay. Now again, I already divided it by 2 because it's 90 mg per kilo per day divided twice a day, so now it's 45 per dose. So we get a total 900 milligrams per dose. You will then take the concentration, which I divided out here to be milligrams per ml, and I just take that 900 milligrams per dose divided by 80 milligrams per ml, and guess what? The milligrams will cancel out, and then I have 11.25 mLs. Now, if you rounded that to 11.3 or 11.2, that's totally fine, right? It just depends on what's going to be easier to measure for your patients there. If you round it to 11, would you be absolutely wrong? No, if it's within 10%, you're probably okay. So really you have, 1.125 mLs to kind of play with there. So if you round it to 11, I probably wouldn't fault you. If you bumped it to 11.5, I probably wouldn't fault you either. But really it just depends on the provider, how exact you want to be there. So we need to figure out how much to give them. Now we want to devise a plan for monitoring, right? So we should be able to describe it to the patient or to the caregiver, depending on, how old the patient is, and, how to monitor for efficacy. What side effects you worry about? What are things that are normal and expected, and what are things that are really worrying, right? So if you give a kid antibiotics and they have diarrhea, that's nothing I'm too concerned about because that's pretty normal. We know that's going to happen in a lot of situations. If the kid starts complaining that they can't breathe, that is another story altogether. So some of that may seem obvious, but in some cases it may not, depending on what the patient's sort of education level sort of is. So again, explain rationale for why we use it for as long as we do. So make sure we're using it for the full course. So if they tell you to take it for 7 days, make sure they take it for 7 days, not to stop it early, because one, you could have failure of the drug to where the bacterial infection comes back, or you could preclude them or predispose them to becoming resistant later on. So if they get another infection, maybe amoxicillin worked before, but now it doesn't. Now it's resistant to that, and you got to bump it up to something with wider coverage, for instance. And again, explain what should constitute a change in therapy. So allergic reactions, if they don't start to improve over the next 2 to 3 days, make sure that you call back so that way you can change it out to a different prescription. And then, of course, plan that program of education. So find a way to educate your specific patient there. So again, if it's like a 2 or 3 year old, probably not going to be able to tell them a whole lot, depending on how savvy they are. But as they get older, as they're adolescents, you should be able to explain to them, like, let them know. Don't just talk to their parents, like talk to them too if it's appropriate. And make sure you use educational materials as appropriate to go ahead and make sure they're educated on it. Because a lot of times too, like if you're in sort of a medical setting and you're talking to a provider and they tell you, oh, you have an infection or you have this or that, a lot of people can kind of shut down after a while, especially if you're giving them a lot of information. So it's good to have printouts so that way they can go back and read it later. So like, oh yeah, the PA said something about X, Y, and Z. I don't remember what they said. They can go back and read it and make sure they get the full information there. So now I want to transition and talk more about prescription writing specifically. So looking at a prescription, we know that this is a written, verbal, or electronic order from a practitioner to be fulfilled by a pharmacist, a lab, durable medical supply, whatever the case may be, right? Now, who are typical prescribing practitioners? Certainly have our physicians, or MDs and DOs. We have our PAs and nurse practitioners, so those, whatever term you want to use, advanced practitioners, physician extenders, whatever term is in vogue at the time. I always hate the term mid-level providers because I feel like you guys are excellent providers, so that kind of doesn't really speak to how great you guys are in terms of the medical team. But whatever, PAs and nurse practitioners. But some people you may not think about include things like podiatrists or vets or optometrists. They can all write scripts, right? So really it's just an order to be fulfilled by the appropriate people. Now, in general, you're going to find that there are 2 sets of laws to contend with. There's going to be state laws and then federal laws. Generally, for my stuff, I tend to talk about Florida laws because I presume most of you are going to stick around in Florida and practice here, but just know that it may change depending on where you go to. And for the most part, Florida tends to be sort of slow on the uptake for a lot of these laws. So, for instance, like PAs being able to prescribe controlled substances was like a very late development as compared to like the rest of the U.S. So, we're just kind of a backward state in a lot of ways. But regardless, you're going to see that typically you want to go with whatever is stricter or whatever is more strict. I'm not sure if stricter is really a word or not, but I don't think I got the squiggly line underneath it, so maybe it is. But whatever one is more strict, you want to make sure you don't get yourself in trouble with either. So you just stick with the more strict one. And typically, if it's not addressed in state law, then you just follow the federal law. And you'll get a feel for this over time on what's appropriate and not, especially on rotations. So prescribing errors are super, super common. They are helped by using electronic means of writing prescriptions as opposed to just doing everything by hand. I still think it's important you learn how to do it by hand. And you'll find still a lot of your providers, especially those that are working like in more clinic settings, are going to still have everything written out by hand. So you may be dealing with a lot of this. I know a lot of my clinical year students are dealing with this right now. And they should provide enough information to permit your healthcare staff to discover possible errors, right? So you should have enough information on there so that it makes total sense to whoever reads it. Okay, I know why they're doing this. I know what's going on here. And if there is something kind of funky on it that needs further clarification, they should be able to find that out, right? So looking at prescription requirements according to the Florida statute. Now, you don't have to, I wouldn't say memorize this entire list, but these are things you're going to see and things I include on all my prescription assignments to make sure that you are writing things that are considered to be legal. Now, there's some things I'll include on my prescription assignments that I include from a medication safety perspective that are not according to the law. And again, I'm teaching you sort of like the most strict way to do it. So that way, when you get out into the real world, you can kind of see some of the shortcuts people may take. You can see some of the other ways people will do things. Just know this is sort of like the most strict, and then you may see that relax a little bit when you're actually out there in the real world. So I don't want you to think I'm just practicing in this big ivory tower, I should say, and saying, well, this must be done all the time, because that's not real life in a lot of cases. So basic requirements. And specifically, this is for non-controlled substances. We'll talk about controlled substances in just a little bit, which is kind of a misnomer because we're also controlling prescription drugs technically, but we'll talk about what that controlled terminology really means. So if it's written or typed, it must be legible. They put that into the law because otherwise people will not make it very legible. And even then, it's in the law It'll still not be legible if it's by hand in a lot of cases, but be legible. Name of the practitioner should be there. The name and strength of the drug prescribed. So, like I mentioned when we were going to that Ceftonir, you have to specify the strength. So say it's the 250 per 50 or per 5 ml concentration. Say it's the 500 milligram tablet, whatever. So that way we know when you're saying take 2 tabs, I know what those 2 tabs are essentially, right? The quantity of drug to dispense, the directions for use. So that's the take 1 tab twice daily. Those are the directions. It needs to be dated, right? So the day you actually wrote it, and then signed by the prescriber on the date issued. So you don't want to pre-sign a bunch of prescriptions and have a pad in your lab coat pocket, because then someone can steal that and write a bunch of frivolous scripts in your name there. So don't pre-sign a lot of stuff. Kyle says a lot of MDs out there breaking the law with that first rule. I agree. And that's half the reason why I became a pharmacist, because I have also pretty poor handwriting. So it's like I'm kind of like the illegibility whisperer a little bit. I can read some of that stuff. Regardless, though, you're going to see that also you will find that most scripts are going to be communicated electronically nowadays, either faxed or sent over through the interwebs. And you can even call them in occasionally. And so if you call them in, then at that point it actually has to be a pharmacist who will then reduce that down to an actual prescription. So we can do that as well. This is a good rule of thumb here. So you want to know in general how long your scripts are going to be good for. So all prescriptions are only good for 1 year at most. So you could write a script and you could say write for 30 tabs of a drug they're going to take 1 time a day, so like a month supply, and you could write 345 refills. Doesn't matter how many refills you put on there, it's only going to be good for 1 year. So most of the time if you're doing a chronic med they're going to take year round, you'd write for the initial fill on that script, and then you'd write for 11 refills. Okay, so that initial script is good for that first fill, and then you do the additional refills based off of that. So 1 plus 11 is essentially how we kind of look at that. You may hear that terminology. You can write for multiple non-controlled substances on the same prescription. So you can write for multiple things if you have the space there. I recommend, especially if you're dealing with a tiny prescription pad, to separate it out though. As I mentioned, controlled substances should be separated. We'll talk about C2s in just a minute, but those have to be by themselves. They're on their own script by itself. I'll talk about that in a moment. So here is an example of what this looks like. This should look similar to the example that I give in the rubric, but again, the patient name. This is really handy to have their date of birth. You notice there it was not on the requirements, and again, that's good because you can have multiple people with the same name, so multiple Sean C. Martins that are only discernible by either their address or their date of birth. So you want to make sure you get that straight. A lot of places will have allergies on there. Again, that is helpful. Even though we'll ask the patients on the pharmacy side, do they have allergies? This is helpful if you include that as well, so we can make sure there's no discrepancies. Note here they include the indication. That is not required, but it is useful because you may not always use metformin for diabetes. You might use it for other things. So it's good to let people know, so that way we can check to see, okay, well, for diabetes, is this the appropriate dose? Is this the correct way to use this? And if not, then we may call you up and may get some clarification, right? So this is why I like for you to include the indication here, right? So then they write the refills and then they sign it. Now again, you'll find that for a lot of non-controlled substances, you can do things like stamps potentially. You can do things like electronic signatures, which will be through like a computer system if you're writing scripts that way. Those are appropriate too, right? Again, these are not controlled substances, so they're handled a little less strictly than you'll see with some of the other ones. So what are some common prescribing errors you're going to run into, or you might make again one day? I hope none of you will ever make a medical error, but unfortunately the odds will not be in your favor, especially, presuming you graduate in your 20s and you work until your 60s, assuming any of us ever get to retire, that's 40 years. It's a lot of time to make a mistake, right? So omitting information is a really important one, right? So resume pre-op meds. Continue present IV fluids. You're not really being specific here and saying, well, which meds are you talking about? Which fluids are you specifically referencing here? So be very specific, right? People may fail to discontinue a prior med when starting a new one, right? So you say, okay, well, that drug wasn't really working for your blood pressure. Here's a new script for a different drug. And they may not hear that, okay, I was supposed to stop taking that old one if you were not very explicit about it, right? If you don't indicate between short and long-acting dosage forms, that can be important because a short-acting one may take 3 times a day. Long-acting one, you may only take 1 time a day. And so if you get that screwed up, that can be either getting too much or too little of the drug as it may be. And then if you put as needed or PRN on a prescription without indication for what that means, right? So you can say, well, take this as needed. Well, as needed for what? Maybe you give, we actually run into this quite frequently. If you're not familiar, there's an organization called the Joint Commission. And if any of you know what the Joint Commission is, it's a pretty scary set of words there. But those are the people that basically come through and accredit all of the hospitals. And so you have to make sure you're up to snuff on terms of like safety standards and monitoring and all these sorts of things. And if you don't get accredited by a Joint Commission, then you basically don't get paid by Medicare or Medicaid. And that takes away a lot of your money, and that's not a good thing. So everyone is really worried about passing the Joint Commission evaluation. And in fact, my mom, she was a nurse for all of her days, and she was eventually the CNO for chief nursing officer for a small hospital in Palaca, Florida. And anytime, we always knew when it was Joint Commission time, because she would disappear for like a month practically, working very long hours. And whenever she came home, my dad would always say, just let her be. Do not ask her anything. Do not complain about anything. Just let her go, because she was one nerve away from exploding on us, because she was dealing with all the stuff at the hospital, right? Shelby says all the managers freaked out whenever they came around. Yeah, we certainly do. It can be a scary thing, but assuming you're doing everything right, you shouldn't have anything to worry about, right? About the Joint Commission, it says not to use QD, QOD. Is that new? I still see a lot of that on scripts. Yeah, so I'll talk a little bit about the do not use list in just a few moments here, but there are certain things you should not use, and if they catch you using that, that can be a citation you'll get from them because they are easily mistaken for other signatures. So we'll talk about that in just a little bit. Brian says, I hated the Joint Commission season in the ER. Yep, it's terrible. You have to feel like you're on eggshells the entire time. See, my friend and I worked in the ER. We joked about buying Joint Commission windbreakers and walking around with clipboards randomly. That would certainly not win you any friends for sure. I can tell you that much. Maybe an April Fool's joke or something. As I mentioned, legibility is extremely important, but is generally being supplanted by a lot of e-prescribing. But you'll still find, especially in a lot of your clinic-based rotations, you're going to find a lot of handwritten scripts, and so this is not great. So you want to make sure that you are legible. I'll be the first person to tell you my handwriting is pretty poor, but this is unacceptable. So if I can't read it, you're going to get a call from me to make sure that you can clarify what it's supposed to say. So other types of poor prescription writing. This is a really big pet peeve, and I will catch you every time on your prescription assignments if you do not follow this. So make sure you follow this. I'm emphasizing this because you should do this, or not do this as the case may be. So misplaced decimals, right? This is really important because you can cause either a tenfold overdose or tenfold underdosing of a patient if you miss the decimal place, right? So in terms of things I want you to avoid, so when you want to make sure that you include zeros, a leading zero, before any number less than 1. So for instance, if you're writing for 0.2 milligrams of something, you write down 0.2, because if someone misses that decimal place, as you'll see sometimes in your writing, it may even be faint. That could mean a tenfold overdose. So always precede decimals with a 0 if it's appropriate, right? If it's 1.2, then it's 1.2, but make sure you have that 0 there for anything less than 1. Do not include unnecessary zeros after the decimal. So if something is 1.0, it could be misread as 10. Now, I know a lot of you are coming from more scientific sort of backgrounds, especially in undergrad, and this denotes how precise the reading is, but this is not great. You may still see this in like laboratory readouts and things like that. That's fine, but for prescription writing, don't include leading zeros because that can just be misread as 10, so don't do that, okay? U is another one that's really important. That'll be on that same Joint Commission do not use list as QD, which I'll mention in a second. U, which frequently means units, could be misread as a 0, and you're thinking like, well, this doesn't look anything alike, but again, you're talking about actual handwriting here that could be misconstrued. So 10 U of insulin, 10 units of insulin could be misread as 100 instead of 10, and that could be a lethal overdose of insulin for the patient, right? So always write out the word units. If something says IU, that stands for international units, you don't have to write international, just write units, and that's totally fine by my standards. Other things for poor prescription writing, so misreading micrograms, just write MCG instead of that, because that could actually be misread in some cases as milligram, which would be a 1,000-fold overdose, which is not great. We do not use QD because that can be misread as some other things. So for instance, that could be mixed up with like QID, especially if you're writing quickly. So that could be meaning 4 times a day instead of just the one like you mentioned. So never ever write QD on your prescriptions. I'll definitely get you for that too. Always write out daily. Q daily is fine. Daily, once a day, whatever the case may be. Just write out that. Do not write QD on your scripts. And then this is kind of an old school one, but you'll see it come up occasionally, but not writing out full drug names. Again, I don't see this too often, but MSO4 is sort of an old school way of abbreviating morphine sulfate, but that can be misread as magnesium sulfate. So that can kind of go wrong either way. So if I have someone who needs magnesium, I give them morphine, they may thank me for it because they feel a lot better, but they didn't get the magnesium that they needed for whatever the case may be. And conversely, if someone needs morphine sulfate and you give them magnesium, it's not going to do them any good, and they're going to be pretty mad at you for that. So other things. So make sure that include the strength in the dosage form, because there can be multiple different ones out there for various drugs here. So you've got to be really specific, include the strength and the dosage form. And then don't write in teaspoon or tablespoon, just mLs. Just keep it with the metric system, and we'll figure out the rest. And a lot of pharmacies will hand out dosing syringes nowadays, so that's not a worry there. Make sure to include the quantity of the drug. So make sure it makes sense based on what's prescribed. So as I mentioned, if you're writing for something, take 1 tab daily for, and again, if you don't put a duration on there, it's assumed they're going to just continue it ad infinitum until whenever you discontinue that order. Make sure that the quantity makes sense. So if it's 1 tab daily, write it for 30 quantity, right? Unless you put an actual number of days there. And this is a good thing to know too. If you want the brand name, you have to write DAW or dispense as written. Sometimes there'll be a little box on the script that'll say dispense as written. Otherwise, we have a responsibility as pharmacists to make sure we're giving cost-effective treatment to the patients. And so unless you check that, we're able to sub out the generic. So if you write Ceftonir on your script, we can sub it out as if you write down Omnicef, which is the brand name, I can sub it out for Ceftonir. I can do that as a pharmacist, and that does not break any laws because you did not write dispense as written. Okay, and in general, it's unlikely that you're going to need to do that. There's very rare instances where that actually makes a difference between the generic and the brand. So here is that list I mentioned of do not use abbreviations. So for instance, like using the micrograms, actually writing that U there. OD, OSOU, those can be misinterpreted occasionally, so that can mean the difference between which eyes you're going to be using there versus the ears. So a lot of these are things you should avoid using. And again, when in doubt, just write it out. Just write it out in text. That way that avoids any sort of misinterpretation there. Okay. So other things that can be difficult. So when you say take as directed, that should generally be avoided. The only instances where this is really appropriate is if the dosage form is such that it has all of the instructions already there, right? So for instance, here's an example of a methylprednisolone dose pack. This is, or if you ever hear like a Solumedrol dose pack or something, or Medrol dose pack, this is generally what we're talking about. And again, specifically here, it says, okay, take 6 tabs, and tells you how to take those 6 tabs throughout the day. And you're doing 5, then 4, then 3, then 2, then 1. That's fine. This is why a lot of people like to write for Z packs, and they just write Z pack uses directed because it has all the instructions there. But the most part, that's not going to be appropriate. So if you use take as directed on any of my scripts, I will also probably count you off. So I'm not going to give you anything quite so easy as that, unfortunately. Be careful when you have drugs with different dosage forms. So for instance, this is something you'll hear a lot, like say you're in the middle of a cardiac arrest and someone says, give them an amp of calcium, stat. Like, well, what the heck are you even talking about? Because a lot of code carts, a lot of drug trays and code carts are going to have calcium gluconate and calcium chloride. And while these look pretty similar, they're both 1 gram, they're both 10% solutions, they're both 10 mLs. One should be substituted for the other, right? No, because calcium chloride, based on the fact that it's calcium chloride, has 3 times the amount of elemental calcium as calcium gluconate. So because of that difference, if I accidentally give someone calcium chloride when the provider meant calcium gluconate, I gave them a 3-fold overdose. And on the other hand, if I gave them calcium gluconate when they meant for calcium chloride, then I gave them 1/3 of the dose they were expected to get. So you can see again how this can be problematic. So it would be very specific when you're stating things. I want 1 gram of calcium chloride given intravenously, stat. Like that's a good order because it includes all that information there. Sometimes having different concentrations can be really important. So in that same code situation, if you say, give them an amp of bicarb, okay, well, most people will assume you mean sodium bicarb, but there's 2 formulations there. There's an adult form and then there's the infant form. One is half as concentrated as the other. And also this one is 50 mLs. So you get 50 milliequivalents in total. This one's only 10 mLs. So again, you may be getting a much smaller dose given to the patient if they accidentally pulled the wrong one, right? And it may think, okay, well, it's, it says infant right there. It should be obvious. I'm dealing with an adult patient, but sometimes it's not so obvious, especially if you're in a really hectic, high anxiety sort of situation like a cardiac arrest, right? AMP is all I ever hear them say in the ER. That's scary. Yeah, AMP actually refers to ampule, which is a glass vial that you have to actually break the top of. We use very few ampules, so really it would be more appropriate to say the actual dose. So give 50 milliequivalents of sodium bicarb, right? That's a specific dose. But again, you'll find that a lot of medical dogma will be carried down from generation to generation. So that's my job, is to try to break some of that for you guys. So, and then not being really specific with your unit. So for instance, you'll hear like, start the patient on 20 of dopamine. 20 what? Like 20 micrograms per kilo per hour, 20 milligrams per minute, 20 ducks? Like what the heck are you talking about? Be really specific. I've seen instances where I had a patient one time that came into the ER as an adult patient. They're coming for chest pain. There's a rule out MI, but really severe chest pain, just was not going away with sublingual nitroglycerin. They decided to start them on a nitroglycerin drip. Nitroglycerin, one of the problems you will see when it is given is it lowers blood pressure. It actually helps to relax all that vascular smooth muscle to allow for more oxygen-rich blood to go to the heart, along with everywhere else is going to do that. And so the nurse programming the pump, she actually had two different options on that pump. One was in mics per kilo per minute, and one was in mics per minute. And so she didn't know the difference, and the doc just said, do this, and she was too worried about going back and asking the doc. She's worried about getting her head bit off, that she just guessed which one the doc meant. He actually meant mics per minute, and what she typed in was the mics per kilo per minute. So all of a sudden, that entire bottle of nitroglycerin ran into that patient way faster than what they would have expected it to, and had all of a sudden the patient has like a horrible headache because their blood vessels are the size of quarters practically, pulsing all that blood in their head, along with their blood pressure bottoming out. Now they got to deal with that along with the MI that they possibly had going on. So again, be very specific. And one of the things we'll learn about when we get to the ER section later on is that, especially in the ER, the time between when someone says an order to when it actually gets carried out can be sometimes seconds, right? So especially if you're in a code situation, the doc says, do this, it can be given within a couple seconds, right? Whether it be to defibrillate the patient, whether it's to give a medication there. So that's why I always make sure we do, you do the callback method. So that way if someone says, do an amp of bicarb, I say, okay, so you mean 50 milliequivalents of sodium bicarb given IV? And they'll say, yes, that is what I meant. So make sure that your call and response sort of thing there, make sure you clarify everything, because it's very easy to screw things up, right? So some inappropriate drug prescriptions, you need to be cognizant of contraindications the patient may have to prevent them from receiving that drug, or interactions that may be introduced by adding on a new medication there, and making sure you get the full med list. If you don't do that, there could be herbals and OTC stuff that the patient has on board that you're not accounting for, and that can again be problematic there. Think about physiochemical incompatibilities between drugs, right? You may be giving patients, antacids like calcium carbonate or Tums for their osteoporosis and their mild GERD, but then also they're taking a fluoroquinolone for a UTI, and those will bind up in the GI tract, right? And then just disease state interactions that may pop up. So for instance, if I have a patient who has diabetes and they come in and they've got, bronchitis, and I want to give them some steroids for that bronchitis, well, those steroids can cause increased glucose levels. So that actually can make it more difficult to manage their diabetes because of that interaction between these two. So a lot of considerations. We're going to learn about all of these in the future, so don't you worry about that, and don't feel like you're getting too overwhelmed with some of my examples here. We're going to learn about all these in coming semesters. So one thing I'll mention here is compliance. So this is also referred to as adherence to medications, basically how well your patient will follow your treatment instructions. There's four main types of non-compliance that we're going to see with prescription regimens. You're going to see one where the patient actually fails to get the med in the first place, whether intentionally or unintentionally, where they fail to take the medication as prescribed, where they stop taking it too soon, or they take it inappropriately. So I'll give you some examples of this. So about a third of patients never have their prescription filled. Most of the time it can be due to cost, or it can be actually difficult to find the med in the first place. Maybe there's a shortage, or maybe it's a specialty compounded product and you're having a really hard time finding some place that will compound it for you. compounding pharmacies are very special, and so not that they're special like they're so special, but more like they're very specialized, so there are not as many of them. So you may think, oh, this is a really good product, but if the closest one is 50 miles away, then that may not be appropriate depending on where you're at. Even the time of day. When we first started up Nemours, I don't know if anyone's familiar with the Orlando area around Lake Nona, but it used to just be like cow pastures. Like there was nothing out there, but nowadays it's much more developed. But 8 years ago, which I just had my 8-year work anniversary, which is kind of scary to think about. It was all just cow pastures and not a whole lot out there, like trailer parks and stuff. And so when we would discharge a patient from the ER at 11 o'clock at night and say, okay, go get this prescription filled, your next dose is coming up in a couple hours, there may not be any pharmacies nearby for the patient to actually get that filled, or especially 24-hour pharmacies were lacking at the time. So I live right next to Nemours. They are still Longhorn cattle right next to it. Yes, I got to drive by some yesterday. They were caught out in the rain, but they were yes, quite majestic cows out there. But even their land is starting to get encroached upon by new housing and all of that. But again, they also may lack the perception for the need for medication here. So I always, the thing that always got me really jaded and kind of chapped when I was first interning at a retail pharmacy back in the day. So you'd have people who come in from the ER. They would come to the CVS to fill their prescription. They went in for a toothache to the ER, and they would get prescribed antibiotics and a order for Lortab, which is the opioid pain medication. And they would say, oh, I don't need the antibiotic. Just give me the Lortab. And I say, are you pretty sure? Because you just had a tooth infection, apparently, and you should probably use antibiotics for that. They said, no, I'm good. They just got the pain meds. Nowadays, we're trying to crack down on that. That was a long time ago, and so it's more difficult to do that nowadays. But still, you'll find people who will only get the meds that they want because maybe they're using it for other purposes, right? But don't let me jade you. I'll let the real world do that on its own. The patient may fail to take the med as prescribed, right? So maybe they're taking the wrong dose, or they're doing the wrong frequency, or the wrong route, or anything like this. A lot of it could be due to inadequate understanding of the instructions, which is why I really like that teach back sort of method when you're talking to your patients. So for example, when you say take 2 tablets by mouth twice daily, what does that mean to you, right? Most people would probably think, okay, well, I'm going to take 2 tablets in the morning, or 2 tablets at night. But some people might think, okay, well, I'm taking 2 tablets a day. I got to do it twice a day, so I'm taking 1 in the morning and 1 at night. Again, there could be a lot of misunderstanding here, especially when you're dealing with people who may not have a whole lot of education behind their ears, or a whole lot of common sense in some cases, and they may just not understand. So you got to do that job to make sure that they understand it, because otherwise that's on you. That's your fault, right? So patients may prematurely discontinue meds. People may not assume meds are no longer needed. So for instance, if you're on a 7-day course of antibiotics and you feel better after 3 days, you say, I'm good. I don't need to take any more of this. I'm all better. Or if they see an empty bottle and they presume that they don't have to take any more of that drug, they say, well, they would have given me more if I needed it, not realizing maybe there's refills on there. They should probably go back and continue taking, right? Thought, okay, I took this bottle of lisinopril, my blood pressure is fixed. Well, no, it's a chronic condition. You got to make sure they go back and get more of that. Or they may stop taking it due to lack of perceived benefit, right? So if they don't feel any different, right? This is a big thing I run into with a lot of patients with anxiety and depression. A lot of our long-term chronic depression meds don't really kick in until 2 to 6 weeks after you start them. And so if you're depressed and you're taking this med and you don't feel any better, maybe you're having some side effects from the drug, you feel worse in some instances, you may say, well, I just don't want to take this anymore, and so they'll discontinue prematurely. Or again, if they don't perceive how chronic of a nature it is, they feel better, and then they say, okay, well, I'm good, I don't have to take this anymore, and they stop taking it. You see this with a lot of like bipolar patients who, once they start to hit sort of a manic phase, they will feel like, I'm feeling great, I don't need to take this med anymore, I'm all fixed, and then that's when they can possibly deteriorate. And then some patients will take meds inappropriately. So they'll either share medications with other people, their neighbors, their family members. Maybe they'll take someone else's medications, or they may abuse the drugs, right? So for instance, if someone has an opioid use disorder and they're getting illegitimate scripts filled for pain, and then they continue to take that for their addictive purposes. So, a lot of reasons why compliance might be poor. So that kind of goes into talking about controlled substances. So what is a controlled substance? Well, basically, it's anything registered with a DEA and is considered to have a potential for abuse. And when I say abuse, it means people will take it for some unintended purpose, usually for sort of euphoric type of purposes. And there is a risk for developing physical and psychological dependence on the substance, right? Basically means you can have addiction associated with it. And so they're sort of broken down into 5 different categories based on their risk for developing psychological and physical dependence, right? And also whether or not they have an acceptable medical use. So as you can see here, number 1 is going to be the highest, so it kind of goes in reverse order. So 1 being the highest and 5 being the least controlled. 1 is going to be stuff you're never going to prescribe, right? This is actually has no acceptable medical use and has a high risk for abuse and dependence. Now, again, this is determined by the DEA, the Drug Enforcement Agency, and does not always line up with how the real world actually works. So, for instance, marijuana is considered federally by the DEA to be a Schedule 1 substance. Doesn't mean we prosecute everyone where they have it, for instance, with like state legalization or decriminalization for it. But federally, it's still considered a Schedule 1 substance. Now, I don't know too many people who would consider something like cocaine to be less addictive than marijuana. Marijuana is like practically not addictive. There's some caveats to that, which I'm not going to get into here. But if you talk about the relative addictive potentials of like heroin versus marijuana, like obviously heroin is going to win out there. But regardless, this is how the DEA registers it, right? Anyway, so Schedule 1, no acceptable medical use. You are not able to prescribe that. Schedule 2 are going to have a high abuse potential, high risk for psychological or physical dependence, but there is a current acceptable medical use. So for instance, all of the ADHD meds, they're amphetamine based. So your Adderalls and Concertas and Daytronas and all of that, those are Schedule 2 substances, right? Because you can develop physical dependence on those, and some people will use those for abuse purposes in order to get a high out of that, right? Or maybe to study for all their exams, or whatever the case may be. Then you have Schedule 3, 4s, and 5s. These are going to be regulated similar to one another, and they have sort of de-escalating risk for abuse associated with them, okay? And this changes over time. That list will change as new substances become more abused or less abused, and so we'll see some examples of that in just a few moments here. Now, there are additional restrictions on controlled substances in addition to the normal stuff needed for prescription drugs, as we saw previously. So, for instance, you have to be more specific and have the name and the full address of the patient, or in some cases, you may be using the owner of the animal for use. And you're thinking, like, why would I ever give a controlled substance to an animal? Well, the one that always comes to my mind is the drug phenobarbital, which is a drug we use for epilepsy, but you can also see it used for dogs sometimes and other animals that have seizure disorder. So that's a controlled substance, and so it fits into the same sort of category. I'll never forget, I one time had a patient filling a script for Keflex, which is a pretty common antibiotic, but it was a dose that I've never seen. I was like, man, this looks like as much as a horse would need. And the guy was like, no, it's actually a Burmese mountain dog. I said, that makes sense. The dog was like 200 something pounds or something. Regardless, you also want to make sure that the full name and address of the prescribing practitioner is there, and along with their DEA number. So you, as a prescriber, if you want to prescribe controlled substances, you have to get registered with the DEA, and then you'll get that DEA number. And again, this is a relatively new thing within the past couple of years that PAs can now do in the state of Florida. Again, we're pretty slow to adopt that as compared to everywhere else. And then you have to write out the actual numerical quantity of the drug to dispense. So when I say that, what I mean is instead of writing the number 50, if you want to write for 50 tablets, you have to write FIFTY. Now, why do we do that? Well, because if you were to write out 10, it's very easy, the number 10, someone to put an extra 0 on the end of that. Now they have 100 tabs they're supposed to be getting. So this is meant to deter counterfeit prescriptions, trying to think of the word I'm trying to think of, trying to alter the script in order to get more medications out of it. Now, Schedule 2s specifically, these are, again, going to be separated out. So you're basically going to look at Schedule 1s you're never going to use, right? So that's easy. Schedule 2 is going to have its own kind of category, and then 3, 4s, and 5s can kind of be lumped into one group there. Schedule 2 drugs cannot be refilled, okay? So you can't write for any refills on there. If you do, it's not going to be honored by the pharmacy, right? However, you can write up to a 90-day supply. And you could actually write this out on 3 different scripts. So we do this a lot for ADHD medications, where the provider will write for a 30-day supply, and they'll write for a second script that says not to be filled until 1 month after the original date, and then a third script says not to be filled until 2 months after that date. And so ultimately those 90 days in total. So this is the max amount. And it also has to be written on tamper-resistant security paper. So if someone tried to photocopy it, it would show as being void. Here's an example of what that looks like here. It has void written all over it, for instance. So it also cannot be transmitted over the phone. Now this is changing. There's going to be limited ways to actually transmit these via electronic means, but in general, you can't call in a controlled Schedule 2 controlled substance here, right? So this is the most tightly controlled because it has sort of the most abuse potential associated with them. 3s, 4s, and 5s can be refilled, but they can only have a maximum of 5 refills. So they get the original fill on that script that they bring to the pharmacy, and they get an additional 5. So in total, 6 months of drug is able to be written for at a time. After that 6 months, it is no good anymore. Okay, so non-controlled substances, you got a full year. 3s, 4s, and 5s have 6 months, and then Schedule 2s have no refills. Okay, let's see. Remember the chronic pain doc I used to work for that would try to do that and save patients money from office visits. Is that you mean by writing the multiple scripts, one after the other? That does help out, especially once you hit the patient sort of like in a maintenance mode and you don't need them to come back to adjust their dose a lot, especially with like ADHD meds. That does definitely help out to try to prevent them from having to come back all the time. Because again, they can't just have a phone call it into the pharmacy or anything, right? Because again, I can't necessarily verify who's calling in. As I mentioned, the counterfeit, counterfeit evident paper, there's nothing really proof, anything about that, but these are actually produced by specific vendors, and it has to go through certain control standards to make sure that not just anyone can call up and get their own prescription pads for controlled substances there. And again, this has to be signed by the provider, right? So you actually have to write out sign your name on the actual script itself. Now let's have a little bit of a quiz here, some controlled substance quiz. So think about this to yourself. Normally I'd have you call it out in the classroom, but this is our new classroom. And so federally, what schedule do these drugs fall under? Yeah, I imagine those office visits were pretty pricey there. But federally, what do you think is fall under? So morphine. The morphine sounds like a pain med. This is actually a Schedule 2 medication. So Schedule 2 high abuse potential. So we have pretty tight controls over that. Oh, that's, you can write into the chat too. How about cocaine? Does anyone know cocaine? Let's see if I can give you a delay here. I'm worried there's a storm brewing, so I'm worried about the power going out, so I want to make sure I get through this. Cocaine and marijuana is a C1, I think. Actually, cocaine is a C2. That's one you don't think about very often, but there is acceptable medical use. You'll actually find in some cases for like ENT procedures, cocaine is really helpful because not only is it a vasoconstrictor, because it actually helps to decrease bleeding in an area. Maybe you have an incision going on, and then it actually works as an anesthetic agent. So cocaine, if you ever see like in TV shows where they would rub cocaine on their gums, and that they're actually doing that to see if it numbs up the gums to see if it's actually cocaine or not. So also it used to be in Coca-Cola, which, it used to be lithium and 7-Up and cocaine and Coca-Cola. So those are the good old days. How about methamphetamine? Anyone know that? See, I never saw it using the ED in the 5 years I was there. No, most of your patients are probably using cocaine there in the ER, if I had to guess. I see a lot of cocaine chest pain coming in there. Yeah, so methamphetamine, so it depends on the formulation of it, but methamphetamine itself is still considered a Schedule 2. So obviously if it's made in your own homegrown lab in your kitchen, not so much, but different formulations of this are certainly considered to be Schedule 2. And then someone said this earlier, marijuana is federally still a Schedule 1 substance, right? So, even though certain states have decriminalized it or made it available for medical use, like we've done here in Florida for medical use, federally they could still come in and, say that that's illegal. So, again, this is a weird one. Most of the other ones, though, follow the same between state to federal sort of regulations there. Let's see, I saw patients who did cocaine, of course, sometimes still on their noses, but never saw it used medicinally. Yeah, what's some craziness. We had, initially when we opened up Nemours, we were getting a list of medications needed by all of our providers, and the ENT docs actually said they wanted some cocaine on hand, and so we got it, and we had 4% little vial of cocaine. They never ended up using it, so we had to ultimately end up expiring it. But we carried cocaine to the kids' hospital for a short period of time, interestingly enough. Now, sometimes you'll find state-to-state differences there. So, for instance, there's a muscle relaxant called carisoprodol, otherwise known as Soma, and certain states will actually put that on the controlled substance list. So, for instance, carisoprodol is a C4 in Florida and some other states. Some places it's not controlled. Or we can actually have changes in schedule. So, for instance, there's a drug called tramadol, which is a pretty weak opioid that used to be unscheduled. And this was really popular amongst like nurse practitioners and PAs because you could write for it for more moderate pain, more so than something like ibuprofen or Tylenol would treat. But it was actually good because you could write for it and not have any issues. But now it's a C4 because we did see a lot of abuse around with it. Hydrocodone used to be a C3. That's now been bumped up to a C2 because we did see so much abuse with it. Hydrocodone used to be the number one Hydrocodone-acetaminophen used to be the #1 medication prescribed in America, and now it's really started to drop down because the restrictions are so much heavier on it as it being a C2 versus a C3. So a lot lower prescribing since that change has happened. So that's it for this section, which is timely because I believe the storm is probably going to knock out my power at some point. But do you have any questions on anything? Let's see if the sticky board has anything on here. Yeah, next time we meet, I'll talk more about the exam. So next time we meet, this is going to be on via Zoom, right? I want that to be our review, and I kind of need like little to no lag on our review. It's going to be a Kahoot review. So you've probably done it with Professor Kaplan a few times, so you're kind of familiar with how those run. So we'll do that, and then we'll do a brief section. I want to talk about the autonomic nervous system briefly, because I think that's a good precursor to what we need to know for Pharm 1 hitting the road strong next semester, and then we'll go from there. Yeah, I like Kahoot too. It tends to work out pretty well. Please make sure your names are something you wouldn't mind explaining to your grandma. Otherwise, I'll have to kick you out of the room. That's not great. Someone asked for the prescription assignment. Do we make up an address name for our office? Also, meloxicam's in 2 strengths, 15 and 7.5. Should we start low? That's a good question. Yes, you can make up whatever prescription address and name for yourself that you want. I do not care. Meloxicam comes in 2 dosage forms. I'll let you decide. I want to see what you guys come up with and exercise some critical thinking. But also think about the indication we're using it for. So see what you can find out there regarding that. Any other questions that I can answer for you at this time? If not, you guys have a wonderful day, and I will see you at our next meeting, which will be via Kahoot. So that you should see that invite there. I'll send out an announcement beforehand as well, just so you have the link as well. So I will see you all hopefully in person. Maybe I'll get to see some of your faces. You've certainly seen enough of mine, so we'll go from there. Yep. Okay, what's your question about the assignment, Kyle? There's a second portion of the rubric at the bottom. Oh yeah, so the second portion that's for medication orders for like an in-hospital sort of setting. Don't worry about that. We're gonna do that next semester. We just want to use the one about actual prescription, outpatient prescriptions. You guys all have a wonderful day. Hope that answers your question. Yep. All right. Perfect. I'm gonna end the stream, and I will see you all later.